Go ahead, ma'am.
Good afternoon. I am Dr. M.V.D. Aruna, consultant and clinical head at Oasis Uppal Center, Hyderabad. So today we are here to discuss something about unexplained infertility. So unexplained infertility, by the name itself, suggests that what is the reason of infertility is not known in spite of doing all the investigations and tests. So this is one of the common problems which is faced by nearly 15 to 20% of all the patients who walk in for fertility treatments. So unexplained infertility, we discuss this issue in more depth. So what we see is that this couple have undergone all the basic tests of infertility, as in whether she is ovulating every month, she's having regular periods, she's ovulating every month. All her blood investigations, as like hormone status and other tests, have all been normal. She is not suffering from any known major medical or surgical conditions. There is no other known cause of any illness in the lady. Uh, Tube tests, which have been done to evaluate the patency of both the tubes, have been normal, whether it is done like HSG or any other form of tubal patency test like saline infusions or hycosi treatments. So all basically the tubes have been evaluated and they are found to be patent. Similarly, routine ultrasound, which have been done, much of any concern there. Same if we are seeing the male partner, the basic evaluation, that is the semen parameters, they're all be the volume or it be the numbers, the count, motility wise, or normal, how they are appearing, whether they are normal or not. All these tests are also normal. No other any known illness in the husband, the male partner, or no known uh, any illness which was there in the past childhood or before, which required any admission to hospitals or any other surgeries or anything. So these reports, they are also normal. So basically, the couple will walk in and they will show, Madam, we are having regular cycles and we have taken some treatments also. My ovulation is happening regularly. Every month the egg is getting released. The lining is good. And my husband's sperm count are also normal. Means the tubes are also patent, but also I'm not getting pregnant. So what is the reason why it is happening? This is a common question or query which many of the couples seeking fertility treatments, they ask. So unexplained infertility. So so basically, what is required for a normal pregnancy to happen? So if we first understand the fundamentals of how the pregnancy is happening, like for example, there has to be one egg which is getting released. That egg has to meet. It has to get fertilized by a good quality sperm, and the resultant good quality embryo, which is forming inside the tube, has to be brought into the uterus. It has to implant there and grow there. It has to thrive there. Then only you have a good pregnancy and a good outcome. You can take a healthy baby uh, home along with you. So these are the four requirements for a normal, good pregnancy. So what are the tests which we are doing? The tests which we are doing, like for example, say we are doing scans to check whether follicle is growing, follicle is rupturing or not. So here we are only seeing the follicle. It is not visible inside the scans. So we presume that the follicle has grown and there is an egg inside which is getting released at the time of ovulation. But there is no way we can confirm whether the same has happened or not. Sometimes the egg is getting released, but following the rupture of the follicle. But maybe it is whether it is picked up by the tube or not, we have no means to check it. So we presume that at the time of ovulation, as it normally happens, the tube might have gone and picked up the egg into its cavity. And where similarly, we are just checking whether the semen parameters are normal or not. That is, volume is good, numbers are good, motility is good or not. But what exactly happens to the sperm after the semen is deposited in the vagina, how the sperm are holding good inside the lady's, the partner's uterus or tubes, we have no means to test. There are a lot of conditions where the vitality of the sperms may get affected due to many reasons. So, whether the sperm is holding good there and is able to fertilize the egg or not, that is, whether it is able to attach to the sperm, whether it is able to penetrate into the egg and fertilize the egg or not. These are some of the things which we cannot be monitoring with our clinical ways of treatment. So these are the things which are happening at a very microscopic level, can only be checked inside the under the microscope inside the lab. So many of these things which are happening, the functional aspects of ovulation, the functional aspect of tubal functions, that is egg bidirectional, that is the egg also has to be picked up from one end, and from the opposite end the sperm is coming. Both of them have to meet, fertilization has to happen, and then the egg has to go to the uterus and implant it. So many complex activities are happening inside the tube. Unfortunately, I have no means to check the functional aspect of the tube. So tube is open, that we have confirmed by various tests. So the egg and sperm may be meeting, but what happens after the meeting, whether fertilization is happening or not, the fertilized egg is transferred to the uterus or not, whether it is supported by the tube in this transit of 4 to 5 days inside the tube or not. These are some of the things which remain unanswered, and we have no means to check these aspects of fertilization and the transit from the tube to the uterus. Again, the implantation inside the uterus. This also involves a lot different types of activities across all the departments of the uterine wall, the endometrium. Many cells are there inside the endometrium. How they are supporting the pregnancy, how the body's immune system is working at that time to receive the embryo, to support its implantation and allowing it to grow there or not. So again, these are all some of the question marks. Unfortunately, we also do not have good knowledge of all the mechanisms involved in implantation of the embryo, and we don't have any means to test even the ones which are known to us, because they are all happening at cellular and the molecular level. So though there are advances, but their actual implementation at the clinical level to help the couple have not yet been evolved. So after discussing all these things, we come back again to the same starting point. What do we do now? So, and what is the way forward? So the obvious tests which we have done, like for example for ovulation, semen analysis, tubal patency, and a normal uterus, the routine scans are anyhow there. So what next do we need to do? So unexplained is basically we have to keep on checking whether we are missing anything, or we need to do more detailed study of the factors involved in the entire process. So, so starting from the beginning, again we check hormone status of the lady. Any thyroid disorders are there? Any autoimmune disorders are there for the lady? For example, thyroid functions, any colon diseases, anything which is disturbing her endocrine functions. We try to check all these things. Any environmental pollutants like quality of the food she is taking, quality of where she is staying, whether there is any exposure to endocrine disruptors in her workplace or the place where she is living, whether the quality of the food she is consuming, any other external stress factors are there. These and all we try to see and try to correct. Next, we have to see whether any history of infertility in the family, history of pregnancy losses in the family. If any of these things are pointing to any particular diseases running in the family or not, we do try and check basic karyotyping can be advised to the couple, both the wife and the husband. Any particular diseases, pinpointed diseases can also be looked for again in the same couple. So once we have ruled out all these medical the hormonal disturbances, then the next thing we could check is the uterus to the regular scanning. If it is normal, we can again try and check her again in the mid cycle, and maybe seventh or immediately after the period, and again in the mid cycle to rule out anything suspicious inside the uterine cavity. Even, whether any polyps are there, any fibroids are there, any adhesions inside the uterine cavities are there, any irregularities are there, wherein you can suspect any other things which can interfere with the implantation. So tubal, as we have discussed before, how the egg is getting picked up by the tube, and how the fertilization is happening inside the tube, all these things we cannot see. But maybe in those who are with high risk for tubal diseases like sexually transmitted diseases are there, chronic PI, his past history of PID are there. Those of these high risk patients, maybe we can do a laparoscopy and try and see any lesions are there inside, adhesions are there, or endometriosis, and these are the things which, when they are mild, it may not be apparent inside the scan. So these are the things which can interfere with the ovum pickup or transit of the egg inside the tubes, fertilization and the transit of the embryo. So these are the conditions which we would like to rule out. Again, all the tests are not applicable to all the people. Based on that couple's clinical conditions and the profile of the patients, we can do the whatever test is there, we can do these tests. Similarly, for the husband, any exposure to environmental things like this endocrine disruptors or excessive use of pesticides, the lifestyle, prolonged sitting or working in hot, humid conditions, say things like substance abuse, alcohol, smoking. So these are all the things which can may impair the quality of the sperm. These all things have to be looked into again, and also the coital history of the couple, whether they are able to have regular intercourse, whether they're actually able to perform the act properly, recheck again against any erectile or ejaculatory dysfunctions, and the frequency of the intercourse. So these are all the things which need to be checked and asked and confirmed again, because the couples may not be aware of the actual way of doing sexual intercourse, and they may be having their own theories of which is the correct time of fertility, and when to avoid and when to. All these things we need to correct, check and reconfirm and correct any wrong practices if it is there. So any stress for the sperm, like I have just mentioned, All these factors we have to rule out. Also, the quality of the sperm, whether the sperm are undergoing any stress. These are, we have now some of the tests like DNA fragmentation index. So these are all the tests which we are done, which is abnormal. It may give rise to abnormal quality of the sperms and the embryos and increased risk of poor quality embryos and infertility happening. So any local conditions like varicocele are there which go undetected. So all these things again we need to check and recheck whether any of these issues are there. So in spite of all these things, we have all checked. So then what next we can do? Again, as I have told, uh, check and reconfirm again whether uterus is normal or not. We do a 3D scan. We again recheck the HSC or the HICOC reports which are available. Any laparoscopies earlier which were done for any reason, those and all we check and try to confirm that there are no uterine factors. So once we are confirmed that there are no known genetic or other ovarian or uterine or tubal or the male causes of infertility, then only we treat it as a case of, then only it becomes an unexplained infertility. So when there is an issue, that the couple is unable to have a baby. So issue is there is a problem is there, but we are not able to find the reason of the problem. So problem is there, but we don't find the reason, so we don't know what to rectify. So this is even more difficult to treat. So generally, a lay person's attitude is that there is nothing wrong with me. So what is the need for me to take treatment? Yes. So the answer would be yes. There is no obvious reason of any problem in all these above mentioned things, but still you are not having a baby. That itself is a big problem. So what is the next solution? So especially. So here comes the importance of the age of the lady. What is the duration of infertility? Based on these parameters, what is the history of earlier treatments? So what is the outcome of those treatments? What tests and all have been done in the past? So based on these things, the general consensus across the world is that we suggest the treatment of ovulation stimulation. That is, we give medicines so that at least more than one follicles are stimulated to grow in the uterus using oral medicines. If required, sometimes we may supplement with 1 or 2 injections so that we need more than one good matured follicles, and we ensure that ovulation is happening. Confirm it by doing a scan or by following LH urinary levels through the kits and or ultrasound monitoring, and then opt for intrauterine insemination. So what is happening here is that we are ensuring that good follicle that is growing, so that we are ensuring that ovulation is happening. So we are aiming for more than one follicle, but we don't prefer to have more than 2 follicles. Maximum 3 follicles is what we don't allow, so that we want to minimize the chances of multiple pregnancies. So we are ensuring that we are having good follicles ovulating, at least 2, not more than 3. And at the same time, we are also confirming that, checking that, ensuring that uterus is ready with a good lining, at least more than 8 millimeter or so. And at the same time, we are also helping as in using the semen and preparing a motile preparation of the sperms and instilling it inside the uterus to ensure perfect timing and also enough numbers. So ovulation stimulation, though the lady is ovulating every month and is having regular cycles also, the evidence suggests that ovulation stimulation and ensuring the two follicles are ready for ovulation and timing it with intrauterine insemination, ensuring that the uterine lining is also, endometrial thickness is also optimal. So at least uh, we can try this treatment for at least 3 cycles. 3 to 4 cycles is generally the accepted norm of first line of treatment. It is easy for the couple also. It is very least invasive to the couple also, and also improves the clinical pregnancy rates. So after the fourth cycle, the chances of pregnancy may not increase more. So whether to continue for another 2 or 3 cycles is again debatable. But usually we prefer to move on to IVF once 3 or 4 cycles of IUI are the couple is failing to conceive. Similarly, which are the couples which don't in which we wish to expedite to more definitive treatments like IVF. These would be the elderly couples more than 38 years of age. The ovary reserve is not great. It is because it is less. The quality of eggs will also be less in women 35 years and more. Also, those who have had taken previous treatments already, they have undergone IUIs, they have already undergone various other treatments, and duration of infertility is more than 3 years. So, expectant treatments in these patients may not work out much because we need to do something to the couple before the woman exhausts her ovarian reserve. So in this type of patients, they will greatly benefit if we expedite to IVF treatments. So in IVF, how is IVF helping this couple is that very subtle changes, which subtle defects which might be happening during ovulation, like for example, egg is getting released, but maybe it is not able to properly respond to the trigger hormone secreted in the body. Therefore, final maturation of the egg may not be happening. So this is one of the things which we can confirm inside in an IVF cycle. What is the quality of egg, whether we are getting mature eggs or not, actually whether we are getting any egg from the follicle or not. These are some of the things which we can only know when we are doing a egg retrieval. So many times the follicle may be looking very good in the scan, but when we actually do the retrievals, the aspirate the follicular fluid, many times we find in these patients that the what we call as empty zonas, there is no egg inside, or there are empty follicles may be there. The quality of the egg may not be good. Then they may not be mature eggs. So many of these problems with the egg, the ovum, are evident only following the egg retrieval. So in IVF, what we are at least we can confirm whether we have got a good egg or not, and then we are doing IVF or ICSI. ICSI, we are in ICSI we are ensuring that the sperm is entering inside the egg, the activation of the egg is happening, and the fertilization is happening, and the next day we are checking the for fertilization. So these things which we could not have otherwise tested in the normal clinical ways. So this is one thing which we can do inside the IVF. We can have some idea, better knowledge, and this thing of the quality of eggs, whether we're getting mature eggs or not, whether fertilization is actually happening or not. So these are some of the things which we can confirm, and try to fix some of these things in the IVF labs. So once the in the IVF, once we get good quality embryos, usually the next hurdle would be a good quality embryo, day 5 embryo. At least the self embryonic gene expression has to start on day 3 only. Then only we get a good day 5 embryo. So once we have got good embryos and we are planning for transfer, then the final hurdle of implantation happens. So again, the problems which occur at the implantation stage can be fixed by um, transferring good quality embryos, one or two depending on the previous history we can transfer. Another thing would be to check the quality of the embryo. We can offer pre-genetic testing of the embryos. And the second one would be to check the endometrium, whether it is ready to receive the embryo. That is the time of transfer. We are transferring the embryo in a time which is ready to receive the embryo. So we call it as the endometrial receptive array, which is done to check the window of implantation, which is the best time to transfer the embryo. So personalized embryo transfer can also be offered to these patients. So not one size will fit all the patients. So which person requires which type of treatment can only be decided following after spending time with the patient and reviewing all the old files, and based on their uh, profile we can the conditions of the patient we can design a better treatment for unexplained infertility. So one size doesn't fit all. So we need to individualize the care for these patients. So this is all about unexplained infertility. Any queries, any questions we would like to discuss? So definition, as per the definition, unexplained infertility itself means that we are not able to find a reason for infertility. So most of these causes of infertility happen to be at functional levels. So physically, if we do the tests, they may be all normal. So mostly they are happening at the level of at the functional level. For example, mature egg, maybe ovulation is happening when we are not getting a mature egg, or maybe there is an issue with the sperm. It's not able to penetrate the egg, or it is not able to activate the egg. It is not able to fuse with the egg. That is, fertilization is not happening. There is an issue with the quality of sperm or egg, or there is a problem with the tube, it is not nurturing the early embryo, or there is a problem with the implantation. That is why it's not getting attached to the endometrium. So these are reasons of unexplained infertility. Again, all at very, very basic cellular molecular levels. So can IVF help with unexplained infertility? Yes, definitely it can. It helps. It is one of the available treatment plans for unexplained infertility. Many of the problems which are occurring at time of ovulation, many of the problems which are occurring because of some problem with the sperm and egg interaction, that is egg. Or at the time of fertilization, many of these things can be fixed in the IVF lab. So once we have got a good size of embryos, again we can check the quality of the embryos by pre-genetic testing, and also we can test the uterus and prepare it by checking the window of implantation by ERA tests. So we can make a personalized embryo transfer program and help these patients, especially those who have got long duration of infertility, patients who have crossing 35 and above, and already those who have undergone previous treatments. I think IVF does help these patients. It's one of the type treatments available for these patients. So thank you very much for your patient hearing. You can call on the helpline 7825850116 for any further queries. Thank you.